Hello everyone, my name is John Stahl. I'm a radiation oncologist here at RMC. I've worked here for a little over 3.5 years, and I do work for UAB over in Birmingham as well. I completed training at Yale New Haven Hospital, and this was my first job in oncology. I've worked closely with Drs. Hagler, Conry, and Spermuli over the years, and I've really enjoyed my time here at the Cancer Center. The colon and rectum includes a very long tube that follows your small intestine. It basically runs across your abdomen and down into your pelvis. The end of the colon is the rectum, and that's an area where radiation oncologists can get involved in patients' care. Patients who are over 45 years old, who have a standard risk of colorectal cancer, should talk to their doctor about starting colonoscopy screening. This screening should happen at a minimum every 10 years until they're about 75. Some patients over 75 still benefit from colonoscopy, but that's more of a personalized discussion with their doctor. Patients who have had colonoscopies, who have had polyps removed or any abnormalities may be seen more frequently than every 10 years. Also, patients who are at higher risk for colon cancer may need to have screening earlier than 45 years old. So patients who have a family member, so a father or mother, siblings, or even children who've had colorectal cancer, will adjust their screening associated with how old that person was in their family when they developed colorectal cancer. In terms of screening, the gold standard is actually the colonoscopy, where the endoscopist will insert their scope through the rectum all the way through the colon, and they have a real close look at the wall to make sure everything looks normal. There are some new technologies that can detect small amounts of blood in the stool, and that's actually testing done on the stool itself. It can even be done at home. Newer testings are evaluating DNA characteristic of cancers within the stool. So we know that certain types of mutations in the DNA, which is the genetic makeup of a cancer cell, follows a similar path where we're able to predict when certain types of DNA mutations might be a sign of a new cancer developing. In the future, there's actually a blood test that may also help us with patients who are not able to get colonoscopies for one reason or another. So patients who have rectal cancer in particular may meet the radiation oncologist to discuss the benefits of radiation in their case, but not all patients with colorectal cancer will meet a radiation oncologist. In fact, the majority of patients who have a colon cancer, which is not in the pelvis, are able to undergo resection and may or may not require chemotherapy, but they'll never meet the radiation oncologist. The reason we're involved is that surgeons can have some difficulty in the confines of the pelvis, which is where the rectum is located, and it can be more difficult to clearly cut out the tumor without leaving any microscopic tumor cells behind. So radiation serves the purpose of sterilizing that area or killing any microscopic cells that may remain. Now, not all rectal cancers need radiation either. The way that we decide if rectal cancer requires radiation is we do a staging procedure where an ultrasound is inserted into the rectum, and it is able to determine how far into the wall of the rectum the tumor has eroded. More advanced tumors are more likely to benefit from radiation, and also tumors that have lymph nodes that are positive. Patients will often get chemo and radiation, and often radiation and chemo at the same time prior to their resection. We know that rectal cancers can shrink really markedly with radiation and chemotherapy, and this can make the surgeon's job easier. For instance, tumors that are very close to the anus, which is kind of the barrier for the stool to leave the body, can be at risk of having what's called a colostomy bag, which is an external device that is able to divert stool away from the anus, which is the more natural way of having a bowel movement. Now, this is a quality of life issue for patients, and whenever we can, we try to allow a surgery that does not lead to a permanent colostomy bag. And radiation, in some cases, can make that less likely by shrinking the tumor and allowing the surgeon to cut it out safely while sparing the anal complex, which allows normal bowel movements. The duration of radiation is variable. It can sometimes be over 5 weeks of Monday through Friday daily treatments. Sometimes it can be done in only 5 treatments. Your doctor will let you know which is preferred. We know that radiation to the pelvis can reduce the risk of the cancer coming back at that location by at least 50%, probably a bit more than that. So we know it's an effective treatment. So the side effects of radiation are variable depending on the person, but a few things that essentially all patients will notice will be some fatigue and potentially a little skin irritation on the area overlying where we treat. Patients can develop some irritation to the bladder as well as irritation to the rectum, which can lead to frequent urination and more frequent bowel movements, potentially diarrhea. That typically resolves within a few weeks after the radiation, however. Patients that come in for pelvic radiation often find it to be anxiety-provoking, but after their first treatment, it's fairly anticlimactic in the sense that they come in for their treatment, they meet the team, they lay flat on the treatment machine in a mold that's made just for them to hold them in the right position. A large machine rotates around their body, they don't see anything, they don't feel anything, they're not radioactive afterwards, but the treatment is delivered. In fact, in the first few days, the patient would have no side effects at all. So a lot of patients are reassured after their first few treatments that the course will not be as intimidating as they initially thought.